Hello friends, I am Dr. Sandeep Hatwar, laparoscopic and endoscopic pediatric and neonatal surgeon. Pediatric and neonatal surgeons are those who specialize in operations in children. So today I am going to discuss the importance of MCU. For those who do not know what is MCU, I will put a link in the description box. Please go and watch my video on what is MCU or VCUG. This case is a 5-month-old boy who was antenatally detected to have right hydronephrosis due to pelvic junction obstruction. But postnatally, he had significant bacteriuria and the stream of urine as per parents was good. But to me, it appeared fair. Also, the DTPS scan, which was done twice with catheter in situ and Lasix, suggested that there was a right pelvic junction obstruction causing hydronephrosis. So, on the basis of investigations and clinical findings, it was very obvious that the child should have undergone laparoscopic pyeloplasty on the right side. But it is my dictum to do an MCU, that is a micturating cystourethrogram, in a child who presents with pelvic junction obstruction before the age of 1 year. So that is the importance of doing an MCU. And what is MCU? Again, I'll request you, if you are not aware of it, please go and watch my video. I had put a link in the description box about what is MCU or VCUG. Now this MCU is extremely important as it totally changes the diagnosis and also the treatment plan. Now watch this. This is a live recording of the MCU procedure, and as you can notice that there is a reflux seen on the right side as well as a small reflux on the left side during the filling phase itself. Now the baby has started micturating, passing urine, and during micturation you can notice that the posterior urethra is mildly dilated and there is a significant reflux on the right side and as well as a small grade reflux on the left side. Now this is the post-void plate. The bladder is totally empty. And this is a post-void plate which shows that there is a huge hydronephrosis on the right side. So the diagnosis has totally changed from pelvic junction obstruction to a vesico-ureteric reflux because of MCU. This is the cystoscopic findings of the right vesico-ureteric junction, and on this side this is a left vesico-ureteric junction. As you can notice, the configuration of the right vesico-ureteric junction is totally altered, which indicates that there is a severe degree of right vesico-ureteric reflux. And there are few pus plaques floating in the bladder as well. See, that's the right vesico-ureteric junction. The bladder appears smooth, and this is the region of the bladder neck. Now as I withdraw the scope, these are the posterior urethral walls which are present distal to the varu, a thin rim seen in the posterior urethra. Now this is the verumontanum, placia colliculi, and the bladder neck. The bladder appears relatively smooth, non-trabeculated, although few trabeculations are seen. Now this is the fulgurating loop. That's the bladder neck. Gradually withdrawing the scope into the posterior urethra. That's a verumontanum there. So I withdraw further. And you can see those thin leaflets of the wall which I am trying to engage. was a very thin rim, trying to engage at 5 o'clock position. And passing a short burst of current. Now this is at 7 o'clock position. 5 o'clock is almost done. You can see a cut portion of the wall there. And now even at the 7 o'clock it has been cut. As you can appreciate the cut leaflets. Now when we do this, we don't have to overdo it, because overdoing might cause stricture. So this is all which has been done, and you can very well appreciate the site where the posterior urethral walls has been disrupted. So that is all, and thanks for watching till end.